This course is mainly organized by Pakistan Dental Association Chakwal and we Association of International Dentistry AID has collaborated in this course. So let's start with a brief introduction of AID and then we will continue towards the lecture by Dr. Ashal Malik on treatment of trigeminal neuralgia. Thank you.
It is my pleasure that we are before you, me and President Pakistan Dental Association Chakwal, and on behalf of International College of Dentists, I also welcome you all on this series of trigeminal neuralgia. Before we have covered etiology in detail, and now we are on our way uh, to after diagnosis, we are on our way to treatment. Treatment is a vast subject in trigeminal neuralgia, and I have seen so many presentations that it is sometimes impossible that you are going to cover this whole trigeminal neuralgia in one go. So it may take one or two or three episodes to complete this trigeminal neuralgia treatment. Ladies and gentlemen, this whole series, as it is already in your information, it is not just a clinical presentation or just to pass the time. It is a preparation for the postgraduate student, especially who are appearing in the part 2 of FCPS, and especially for the students who are appearing in final year BDS, and preparing some people prepare for the abroad examination. So this is not a summarized type of a presentation. It is a very elaborated one, and I have tried my best that it should be so elaborated that everybody, even the starting person who has not been with me for the previous sessions of trigeminal neuralgia diagnosis and etiology, must understand. There were many questions reported to me that said, please, confirmation of the trigeminal neuralgia slightly before going to the treatment, you please recall the confirmation. So I just did it is the last slides of the diagnosis, but just to recall the previous knowledge of the diagnosis, I hereby go for the confirmation first. Now, this is a very excellent chart where axis 1 and axis 2 are given. Axis 1 reports to the physical condition and axis 2 relates to the physiological condition. We are in physical condition. Ladies and gentlemen, generally it's neuropathic pain which we used to have in our diagnosis, not the somatic pain. When we go for the neuropathic pain, we have continuous pain and we are episodic pain. We deal generally with the episodic pain when we are trying for a trigeminal neuralgia. Where episodic pain are again of two types. One is neurovascular type pain and second is paroxysmal neurogenic pain. And the trigeminal neuralgia lies in paroxysmal neurogenic pain. However, these are episodic pain. So when we are talking of the neurovascular pain, it comes under the migraine, tension headache, cluster headache, other primary headaches and neurovascular variant type of headache and pains. So we are not going to deal with neurovascular pain. We straightforward go to paroxysmal neurogenic pain, which are of two types further. One is other neuralgia, which we have discussed last time in detail, like occipital, glossopharyngeal, idiopathic, so many neuralgias we have discussed. And now today we are going to discuss the trigeminal neuralgia treatment with reference to paroxysmal in nature, episodic pain, and it is neurogenic pain with reference to physical condition. So after having this neurogenic pain concept, there is a very good chart which actually give a guideline for a newcomer to how to confirm that this patient is a patient of trigeminal neuralgia. So I take it step by step. You just have a unilateral lateral orofacial pain. Patient reports to you with the complaint of unilateral orofacial pain. If it is like this, then what you are going to do, you are going to take the history. Unilateral orofacial pain is there, and what you are going to get from the history, it is pain with the focal or intraoral trigeminal territory paroxysmal character of pain. You have to take this history. If it is there, then that means that this pain relates to trigeminal neuralgia. But if this thing is not there, it is unlikely to be trigeminal neuralgia, because no doubt it is a unilateral pain. But with the paroxysmal character of the pain, it is coming and going and threshold like what we have discussed in detail, electric like pain and like that. If it is not there, that means it is not trigeminal neuralgia. So, okay, the patient right in the start with the taking of the leading complaints and taking the history, and you come to know that the patient is not of trigeminal neuralgia. No, if the patient has this territory in the intraoral and focal level and paroxysmal character of the pain, then it is possible trigeminal neuralgia or possible neuropathic pain. It is now you are gone step forward, that you are now you have to evaluate the person with reference to whether it is a neuropathic pain or it is a trigeminal neuralgia pain. For that purpose, you are going to take the interview, which we have gone in the etiology and diagnosis in very much detail, and you are going to examine the area which nerve is in, what is the trigger point, what is the stimulating valve. It is triggered by maneuver, like touching, like blowing, like water jet, or like that. That means that you are right there in your target. But if it is not there, then what you are going to do? You are going to take again the history, and you will stress the whether the history is better or not. You have missed anything, why the patient has no pain evacuation by the typical maneuver what you are doing. Then you have to go back for the history. But if there is the trigger point and you get the right diagnosis, then what is going to happen? That is a clinically established trigeminal neuralgia, but probable neuropathic pain. Here the word come probable, and this you have to remove it from your diagnosis, that the clinically establishment is not the definite trigeminal neuralgia diagnosis. Now what you are going to do, you are going to have the investigation, and the best investigation is MRI. No other investigation is potential, no any investigation is so potent as compared to that of MRI. After taking the MRI, if you get something, then you are going to have certain different type of neuralgia, and if it is not there, then you have a different type of neuralgia. What is that? I'm going to tell you later on. But you have now the clinically established trigeminal neuralgia. You have to separate it from neurogenic pain. Now, if you have gone for the MRI and you have established the etiology, and then that is the definitely a trigeminal neuralgia established by a MRI diagnosis. And that is, if MRI neurovascular compression with morphogenic changes of the roots of the trigeminal nerve is there, then it is called as trigeminal neuralgia classica. Again, if your etiology is established on the basis of MRI, then you are going to have the classical trigeminal neuralgia. But if you don't get it, then you have another type of trigeminal neuralgia, which is called as secondary trigeminal neuralgia, which may be related to any neurological disease. That is sclerosis, that may be systemic sclerosis like hemangioma, meningioma. There is so many lesions we have already described in etiology, and that may be related to that secondary trigeminal neuralgia. But if their diagnostic tests absolutely do not give you, but you have the clinically established trigeminal neuralgia, then it is called as idiopathic trigeminal neuralgia. Idiopathy is with relation to no any finding with MRI neurovascular level or MRI with reference to neurological disease or tumor or like that. So that is why it is will be labeled as idiopathic trigeminal neuralgia. Classical must have a neurovascular compression area. It is called as classical. There is definitely a neurological disease, tumor or lesion, then it is called as secondary trigeminal neuralgia. You have no any neurovascular or neurological disease available in trigeminal in MRI, then it is called as idiopathic trigeminal neuralgia. This is the summary for the confirmation of the trigeminal neuralgia. Now we are coming to the treatment. When we are talking of the treatment of trigeminal neuralgia, it opens the sea for us. There are medical treatment, there are surgical treatments, there are so many treatments. And what is the aim of the treatment? The aim of the treatment is to protect the etiology, to overcome the etiology, to interrupt the temporal submission of afferent impulses, which is the basic etiology. If our any treatment is capable of interrupting temporal submission, that means that this treatment will be effective. If it is not, then we have to look for another treatment. So this is the aim of our treatment. And what are the options? We have the medical options, we have the surgical options, oral drug therapy, just medicine, then injectable, different injectable we will discuss in detail. Then there are surgical, extracranial procedures that the maxillofacial surgeons used to perform, intracranial, surgical neurovascular compression, and stereostatic thermocoagulation of the ganglion. These all we will discuss step by step. The first thing we are going to discuss, there are so many alternate options. And these optional, there are research papers regarding these options, acupuncture. There are routine, our classical type of medicine. Even in Pakistan, there are so many medicine, Ayurvedic medicine they are used. Botulinum toxin is recently introduced, and there are many centers who are doing these studies for the botulinum toxin. Exercises and running and all these related things with reference to the physiotherapist, they are also promising one. Homeopathy, hot and cold compression for the lesion, whether it is inflammatory, it is non-inflammatory, yoga, biofeeds, hypnosis, low intensity lasers. Especially, I'm talking of the diode laser at the 780 to 890 nanometers. there are so many studies. We will, when we will go forward, we will study regarding the soft laser application on the trigeminal neuralgia as well. Then is myotherapy, especially the skeletal muscles. Then osteotherapy is also one of the era where people has worked for that. Then that is the trans myocutaneous electro neuro, what you say, synaptic therapy. And these therapies are also very common, especially with the physiotherapy therapist. Vitamin B12 injection, it is in approximately in 1953. It remained very, very common, and you people used to say that vitamin B12 is a reparative agent for the last myelin sheet at the level of ganglion. So these are the other treatments which are also very common. Ladies and gentlemen, we just today we will go for the medical treatment of trigeminal neuralgia, which is the practice of the day and practice of every dental surgeon. And especially I am talking of the maxillofacial surgeon, they are used to have this treatment every day. But the concept of the medical treatment is very important, and that is that what happens in the nerve when there is any neural problem. Damaged nerve ending exhibits abnormal and spontaneous increase and evoke the activity partially due to increase in expansion of sodium channels. That in the etiology we have seen that the sodium channel, they are very much exaggerated and their potential is increased. The peripheral hyperexcitability is due to the molecular changes at the level of the peripheral nanostructure in the dorsal root of ganglion that we have seen, especially in the spinal root. These season changes include abnormal expression of the sodium channels, increased activity of different receptors, and hence it altered the calcium influx into them. Now, this is what there is expression of the sodium channel increase, and there is increase of the calcium influx in the cell. So any medicine which is going to prevent these two mechanisms is going to help us in the management of trigeminal neuralgia. And what is those drugs? These drugs are actually anticonvulsants. What they do? The medical management with anticonvulsant medicine is considered as the first line of treatment for the trigeminal neuralgia because they are very potent sodium channel blocker. And what they do, that they actually act on the areas of nanoreceptors and neuron which have the higher generating sodium channels, it used to block. This type of increase of sodium channels, when it is there, it increases the depolarization. And by the anticonvulsants, depolarization is stopped. So affected fiber and results into increase of spontaneous pain is reduced by the use of anticonvulsant. This is the theory behind anticonvulsant, what we used to do. Now, in summary, anticonvulsant inhibit the reduced synaptic transmission. They have the very good diagnostic value. They are the first choice of treatment options. And systemic side effects, no doubt, is a long-term use. There are always the limits of these systemic use of medicine. Long-lasting therapy without any mortality, they can be possible with this certain medicine, and these are being practiced. Now, when we talk of the medical history regarding use of the drugs in trigeminal neuralgia, quinine was the first drug which was used. then mercury, opium, arsenic, powder of glycinium, trichloroethylene, stibamidine, phenatine in the century 19. 1800 we have just a zigzag pattern of the medicine without any definite clinical trial. But in from the 1936 we have pure anticonvulsant in the market. Then ferrous carbonate in 1944, sodium diphenyl hydrogen in 1942, and then in 1960 and onward, we have the range of anticonvulsant with reference to carbamazepine and other. But when we now look in the market, it is like this. The whole area of the medicine is full of the trigeminal neuralgia treatment medicine. So many medicine, they are being practiced in the daily use. And when we take the literature, we'll come to know that it is not only these medicine which are right in front of you. There are so many medicine which are being practiced in routine way. And that is, you see, carbamazepine, oxycarbamazepine, chlorophenazine, phenatine, baclofen, tocardinine. Then these all medicine, gabapentin and chlorozepam and sodium valproate, then lamotrigine, and these all that valproate and others which are not even anticonvulsant, they are also used. So there are approximately 26, 27 drugs are in market which are being used for the treatment of trigeminal neuralgia. And these all medicine are being practiced by the neurosurgeon and general physician and maxillofacial surgeon and dental surgeon alone or with the combination. And sometimes there is no guideline. And today's lecture benefit is that we are going to have the use of the medicine with reference to special guidelines. The first drug which I am going to take is the carbamazepine. It is the routine drug or the first line of treatment typical for the trigeminal neuralgia. It is in trade name it is generally called as Dagrol. It is manufactured by the SIBA. Its starting dose is 100 milligram PID, that means that 200 milligram a day. Maintenance dose is up to 1200 milligram per day. Its half-life is 36 hours and it remains in the body after few weeks even. Peak serum level is attained in 2 to 3 hours and its peak level maintained for 12 hours. And that is the so maximum period where its peak level remains. Then after that you have to repeat the dose. The serum therapeutic level remain up to 12 hours. And that is a very important thing that these moles remain in circulating. Ladies and gentlemen, what is its action? It generally depresses post-tetanic potentiation at the spinal cord level. So its action is at the first level neuroreceptors. Depress the synaptic transmission to the spinal trigeminal nucleus. From here, if you block in the initial stages, that we have seen the long threshold fibers, and it's used to block the long threshold fibers in many initial stages. Its mode of action, what happens that if you have a very precise way of giving carbamazepine, ladies and gentlemen, I give you guarantee that even this patient will not report you back if the carbamazepine is given in a very authentical and pharmacological way. The main problem with the patient is that the patients are not taking carbamazepine on a actually prescribed way. They used to do the medicine use whenever there is severe pain. They used to take 4 tablet, and when there is no pain they omit it for approximately sometime one week. Now what happens, try to understand that the half life is 12 hours, and after that if used to remain circulating its byproduct for approximately 4 days. Many studies has been evaluated that the carbamazepine threshold level remain up to 4 days. So it is better that the categorization of the carbamazepine therapy should be rendered on the 4 days therapy. And you have to educate the patient that how to use this carbamazepine. Rather make this graph which is just in front of you, that you ask the patient to use this graph a whole the life. Say the patients come to you and you start the patient with 1+1. This dose is called as the maintenance dose. Any patient with trigeminal neuralgia, you ask the patient that you have to take this medicine your whole the life, and this is your maintenance dose. You cannot omit this dose all the life, and that is mandatory. Now, patient says that I have taken this tablet as one evening, one morning, but don't say patient like this one evening, morning. I used to say, give the patient timetable, like say 9 a.m., 9 p.m., like this. The exact 12 hour should be there, that their maintenance dose should be taken in time. Then, if the patient says that I have pain, you add 1 tablet more, and that 1 tablet is in the day. And that should continue for 4 days. And that should be also given. You ask the patient that take the tablet at 6 a.m., then take the tablet at 2 p.m., then take the tablet at 10 p.m. 6 a.m., 2 p.m., and 10 p.m. That is the exact timing you have to describe to the patient, that these are the timings you have to take. It is not, don't say it morning, evening, and in the day. Don't say like this. Say that you have to take it in the mornings at 6 a.m., then you have to take it at 2 p.m., and then at night 10 p.m. This he will continue, or she will continue for 4 days. She reports to you after 4 days and says that yet I have pain. What you are going to do? You are going to increase the morning dose, and that is 2 morning, 1 at 2 p.m., and 1 night at 10. This is run for 4 days. Now, even after 4 days, patient reports to you that I have pain. What you are going to do, you are going to increase the dose, and you are going to give 2 more in the day. 2 morning at 6 a.m., 2 at the midday, 2 p.m., and 1 at night. That is, will continue for 4 days. And if yet the patient says that he or she has pain, what you are going to do, you are going to increase the dose to TDS for 4 days. Now, this is simple carbamazepine therapy. You have not added any medicine to it. You have not added anything to it. This is just plain one drug which you are using, and that is carbamazepine. Now, as you are moving forward, you are going back to the as well. Now this is very interesting chart. The patient has taken 4 days medicine and patient is at 2 morning, 1 midday, 1 evening, and patient says after 4 days
हम्म?
I am fine.
2 दिन पहले
The
दो.
patient says
दो
that I
दिन.
am fine.
हाँ?
After 4 days, patient said I am fine. When what you are going to do? You are going to ask the patient reduce the tablet. Come to previous 4 days. It is like this. Now you are coming back. After 4 days, if the patient get relief, don't stay on this tablet more than 4 days. Try to come back. Patient say, I am fine, sir. Even after 4 days, I am fine. You ask the patient, come back at the maintenance store 1 BD and don't leave it. But if the patient says that I have started pain again after 4 days, now you, rather than going back, you will shift patient to the forward and you will again go for the 211 for 2 days. And God forbid, if the patient after 4 days says that, sir, I have not got relief, you shift the patient to the upper level, 2 morning, 2 midday, 1 evening. And here, patient say, I am fine, sir. No, you will not allow the patient to stay on this therapy more than 4 days. After 4 days, you will shift the patient to 211 and keep the patient for 211 up to 4 days. And patient says, yes, I am fine. Shift the patient down 1 TDS. And if the patient says, no, I'm not fine, you are going to shift the patient up. And if the patient is not fine here as well, you are going to shift the patient more up. And but after 4 days, you will not going to stay here. After 4 days, you have to come back here. And here patient is fine. You are going to come back again after 4 days here. And you are going to come back after 4 days here. And here patient says, I have pain again. You shift the patient up. This is the pattern going up and going down. The thing is that only this 1 BD dose, 1 morning, 1 evening, one at night, 1 in the morning, 9 a.m., 9 a.m. This is maintenance dose for whole the life. But other these doses are only meant for 4 days. That means that you are going to maintain the peak up to 16 days. After 16 days, you will try to come back, then come back, and we are going to have this up and this down mechanism all the life. Do educate the patient that this is your maintenance therapy and you are going to work with this maintenance therapy of the carbamazepine all the life. Ladies and gentlemen, I give you so many examples of my patient that they have started this uh, maintenance doses and this therapeutic guide, and yet they are enjoying without any complication and like that. So this is what the carbamazepine therapy is required. Advantages of carbamazepine are it is very good initial stages. 1200 milligram is the safest dose. It is always used as a diagnostic tool and it has a very good oral absorption. Some people do recommend, I generally say that whether it is therapeutic or not, when there is severe pain, they ask the patient to dissolve the tablet in the water and take it and keep it on the mouth because the oral absorption is very good. So sometimes it is like this. Now, what are the adverse effects? Drowsiness, dizziness, then gastric problem, nausea, anorexia are very common. Serious potential side effects are aplastic anemia, neutropenia, and thrombocytopenia. And rare are water intoxication, CSF intoxication, hepatotoxicity, and dermatological reaction. Ladies and gentlemen, carbamazepine, if the patient is giving, you ask the patient to have the check of the blood after every 4 to 6 months, and that is LFT. That is very important for the patient who is taking the carbamazepine. Have the routine complete blood picture, and good that if you go for the RFT as well, renal threshold test, and renal all test, and especially I will refer that LFT is very mandatory. A complete blood count, hepatic and renal function should be performed before the start of the therapy and repeat quarterly. That is very important for the carbamazepine. Start the therapy from the minimum effective dose that we have described in a very efficient way. Stop the therapy if leukocyte count drops below 3000, absolute neutrophil count drops below 1500, and serious reaction or side effects occur, which is generally very rare in carbamazepine. But if it is there, then you have to stop the therapy. This is what the carbamazepine is. Ladies and gentlemen, this is a very important drug. If a dental surgeon or a maxillofacial surgeon or a physician is having a good knowledge of
Excuse me,
use
sir.
of the carbamazepine,